Now, it gives me great pleasure to welcome Dr. Patrick Harrington from Guy's and St Thomas's. Patrick has been the clinical lead on the development of the app and is going to talk to us about that. Welcome, Patrick.
Thanks, Nona, and thanks for the invitation to speak here. It's wonderful to see so many people here today. So I'm going to provide an update on a project that many people will be familiar with. In fact, some people may be part of this project in the room, and that's the development of the MPN app, which we've called My MPN Voice. And I'm going to discuss how we can use this to support patients and to support clinicians in managing patients with MPN. So, by way of background, what do we know about symptoms in MPN? Well, we know that patients with MPN have significant symptom burden. It was reported that over 90% of patients with MPN diagnosis have symptoms that affect their quality of life. And we know that symptoms can also be useful in helping to determine selection of therapies and can also be used as a marker of disease progression. A survey of MPN clinicians was published in 2020, which looked at the use of formal symptom assessment tools in MPN patients. And it was reported that whilst over 90% of clinicians look for the presence of constitutional symptoms, only just over half reported using a formal validated symptom assessment tool. Within that, over half of these patients use these tools to track treatment response, and just over a third use these tools to help with decisions around initiation of treatment. There's also increasing data on the use of patient-reported symptom monitoring. So this graph here shows survival in patients with solid tumour, so not MPN patients, but this shows that patients who engaged in a patient-reported symptom monitoring program actually had improved overall survival compared to those who did not. And that was presumably due to earlier detection of recurrence of their condition or earlier detection of complications. We're also now in an era where we have targeted therapies that are extremely effective at reducing symptom burden, and that's particularly the case with the JAK inhibitors, so ruxolitinib or perhaps momelotinib nowadays, and these are used for both polycythemia in the case of ruxolitinib and myelofibrosis. And so there's accurate monitoring of the impact of symptoms and with these treatments is really important. So the data shown here comes from the COMFORT-1 study, which assessed the use of ruxolitinib compared with a placebo in patients with myelofibrosis. And what this graph shows is the percentage of patients who achieved a greater than 50% reduction in their total symptom score. And as you can see, this was achieved in around half of patients taking ruxolitinib, compared with only around 10% of those patients receiving placebo. In addition, the majority of patients receiving ruxolitinib achieved this response within the first 4 weeks of treatment, and this was maintained up to 24 weeks of follow-up. And still to this day, new treatments for MPN are often strongly based on the reduction in symptom burden that they offer in terms of the licensing. So as a result of all this, we developed something called the My MPN Voice App to monitor patient-reported outcomes in MPN with an associated research study around the collection of biometric data, which I'll go on to discuss more, but they come from the smartwatches shown here, and this, which feeds directly into the app. And we've also set up the ability to access data from electronic health records as part of the research project as well. So shown here are some screenshots demonstrating how the app looks, and you can see here the MPN 10 total symptom score, which is the primary patient-reported outcome tool that we're using, and it lists each of the 10 most commonly reported symptoms in patients with MPN, and they can be ranked on a 0 to 10 scale to provide an overall score out of 100. So I'm not going to go into any more detail now on the functionality of the app, because Debbie, who's speaking next, is the expert on that, and she's going to go through that in great depth, lots of nice screenshots. So I'll move on to some of the details around the study. So the workflow for the study is shown here, and it's quite an unusual study design in that it doesn't require any specific attendance at any hospital site. It can all be done remotely. So patients self-refer, and it's typically through advertisements on social media or through word of mouth or perhaps through events like today. And then patients are provided with a digital patient information sheet, which provides all of the information that you might want about the study. And if they are interested, they can then subsequently sign a digital consent form, all done online. They will then be sent a wearable device if eligible, and then will be provided further support with the onboarding process, which really allows the user to get support with the technology and get familiar with everything. I should point out that there are 3 cohorts with this project. So the first cohort is the research study in which patients enter their data and it goes into the study, and they also receive a wearable device. Unfortunately, we only have a finite number of wearable devices, so not everybody will be eligible to receive a wearable device. So some people, if they want to be on a research study, will just go onto that but not receive a wearable device. And some people may not want to be part of a research study at all, which is completely understandable, in which case they will be able to use the app and report their data and monitor their outcomes, but their data won't go anywhere. It will just be for them. I want to just highlight at this point that this project is an official research study, so I just want to reassure everyone that it's gone through very rigorous steps to ensure that everything is done correctly, and particularly around the security of patients' data. So the study is sponsored by Guy's and St Thomas's NHS Trust, where I work, and as such, GSTT owns the data. The study has been approved by an internal research and development department and has also gone through external ethical committee approval. All data that we receive is confidential and anonymized. It's held on a cloud-based system that's secured using Microsoft Azure, and it's fully compliant with various regulatory standards such as ICO and ISO. And of course, patients are able to withdraw at any time if they choose to do so. So where are we now with the study? So we launched back in April of this year, so we've been up and running for just over 6 months now. We have 221 patients who've been recruited, with 212 of these regularly reporting their outcomes, and nearly all of these patients so far have received a wearable device. Of these patients, 108 have a diagnosis of ET, 77 PV, and 32 myelofibrosis, with the remaining patients falling into the other category. The median age of users is 59 years, so fairly reflective of the MPN patient population, and we have a really wide range of 24 to 83 years, which is nice to see. And it's also notable that 2/3 of participants are female. A couple of patients have dropped out due to exacerbation of underlying health anxiety issues, so that's something that we do mention to patients as part of the onboarding process, and we screen for that to make sure that's not something that could be an issue. What's happened there? Okay, so moving on to look at some of the preliminary results. So far, we've captured over 1.1 million data points across 70 distinct variables, and this includes 15,168 individual MPN-10 total symptom scores. So if we look at the data shown here from the MPN-10 TSS, over the whole cohort, we see a mean score of 13.7, with PV patients actually reporting the highest score. So the different disease groups are shown by the different shades of blue, myelofibrosis indicated by this pale shade here, ET by this darker shade, and then PV shown here. The MPN-10 TSS was fairly similar across the different disease subtypes, but if we look at individual symptoms, what we can see is that fatigue is the most commonly reported symptom, as shown here, and that's perhaps unsurprising. There was also notably high levels of concentration issues. Inactivity was also highly reported across all disease subtypes. I just wanted to point out a couple of other things. So we can see that within the PV group, itching was particularly prevalent, as you can see by this bar here. It was significantly higher than in the other groups. And within the myelofibrosis patients, night sweats was a particular issue, as we often see. So moving on to the quality of life score, which is called the EQ5D5L. And this is a score that's widely used in patients with chronic disease, but hasn't been previously assessed in the MPN patient population. So this score includes 5 different dimensions: mobility, self-care, pain or discomfort, anxiety or depression, and the impact on usual activities. Scores from each individual metric are combined to give an overall score, which is inversely related to the score for the individual parameters. So if you score very high for pain and discomfort and high for self-care issues, that will result in a low overall EQ5D5L score. And again, the different MPN subtypes are highlighted by these different coloured bars for different shades of blue. And what we see here is perhaps more reflective of what we might expect amongst the MPN population, in that the myelofibrosis patients had the lowest overall quality of life, with the highest issues with pain and discomfort, highest issue with usual activities, and issues around self-care and mobility. In contrast, the highest quality of life was observed in the ET population, as you can see here, with the lowest impact on usual activities, lowest impact on self-care, mobility, and lowest pain overall compared to the other subtypes. Moving on to look at some of the biometric data that we're capturing by these smartwatches. So on your left here is data for activity. And what we see here again is that myelofibrosis patients have significantly lower levels of activity, and that includes of all different types of intensity. So intense, moderate, and soft activity were all lowest in myelofibrosis patients. They also had lower step counts and lower distance travelled when compared with ET and PV patient groups. And on the right are the sleep metrics, and again we're seeing that myelofibrosis patients had the highest wake-up count, as shown by this bar here, and the highest wake-up duration, with ET patients having the greatest overall total sleep duration. And this is novel data in the MPN patient population. No one's really looked at these kind of metrics before, so quite interesting. Moving on to look at some of the individual MPN subtypes dependent on the treatment that they have received. And shown here is the data from the ET cohort divided into hydroxycarbamide, interferon, and active surveillance groups. Notably, the highest EQ5D5L score and the lowest overall MPN 10 total symptom score were both observed in the patients within the active surveillance group when compared with both interferon and hydroxycarbamide treatment groups. Patients receiving hydroxycarbamide recorded a higher MPN 10 total symptom score overall, and also higher severity scores for most individual symptoms, which are shown by this image here, which is a spider diagram, which represents the individual symptoms that are being experienced, and each of these lines represents a different treatment modality. So this outer line here is, actually that's the wrong image, so I'm just going to skip past that. Sorry, something's happened to the slides here. Moving on to the PV cohort, what's striking here is that patients receiving ruxolitinib had the highest MPN 10 TSS with a mean score of 21.7, and this was associated with the lowest overall quality of life score. This could be due to the patients by nature being a very high-risk group, so by nature they would have been refractory or intolerant of other first-line treatments, so it's unclear how much of this is cause or effect. And what we're planning to do in the future is perform analysis over time in individual patients to assess how each of these treatments affect symptoms longitudinally. Other findings here were that patients taking interferon had slightly higher symptom burden and lower quality of life score than those taking hydroxycarbamide. And again, patients not taking any treatments had significantly lower overall MPN 10 TSS with a mean of just 7.9 and the overall highest quality of life score. Moving on to look at the myelofibrosis data, noting a relatively small number of patients at this point in this cohort, what we see here is that the TSS is notably lower in those patients receiving JAK inhibitor therapy, whether that's with ruxolitinib or momelotinib. And this is in keeping with what we expect, given that we know that constitutional symptoms are frequently observed in patients with myelofibrosis, whether they have high or low-risk disease often, and these symptoms are really effective at treating these symptoms, as we saw earlier with the data from COMFORT-I. Patients taking hydroxycarbamide again had the highest MPN 10 TSS and lowest EQ5D5L score. So this is quite a complex slide, and essentially I'm not expecting anyone to interpret this. I'll just give this as an example. So this is a correlation matrix for the whole cohort of patients, so everyone of all disease subtypes. And what we're looking for here is positive and negative correlations between each of the individual variables from both the biometric data points and the patient-reported outcomes. And what we're really showing here is the extent of the data that we can capture using this approach. So as an example, if we look at this line here, which has some squares highlighted, this line here represents the MPN 10 total symptom score, so the total aggregation of all of the individual symptoms. And what we see is that this is negatively correlated with metrics such as active duration, distance travelled, sleep score, and sleep duration, amongst many others. So greater symptom burden is associated with less activity, so nicely bringing together this biometric data and patient-reported outcome data. And we've looked at this across each of the individual MPN subtypes as well. So what are we going to do next? Well, I mentioned earlier the potential for accessing data from electronic health records, and this work is ongoing. So as part of the onboarding process, participants are asked to complete a subject access request form that allows us to retrieve certain relevant information from electronic health records, which is summarized in this table here, but includes things like radiology and bone marrow biopsy reports and blood results. So far we've received data from 83 patients in terms of their hospital records and 60 patients from their GP records, and we're still pursuing this. But what are we going to do with all of this vast amount of data that we will receive? So the way that this is going to be managed is using a form of machine learning called natural language processing. We've actually recently published a manuscript from a separate project that used this approach to assess the frequency of thrombotic events and cardiovascular risk factors in MPN patients. I'll briefly just summarize what the approach involves. So we know that electronic health records hold lots of data, but it's really mostly in the form of unstructured text, which makes it really difficult for this to be used for computational analysis. So natural language processing is designed to overcome this by making the data accessible for computational analysis. So the workflow from the previous project is shown here. And what this shows is that we use a set of software tools called CogStack, which firstly retrieves the information and standardizes it, looking for things called SNOMED CT codes, which essentially are diagnoses. We then use something called the Medical Concept Annotation Toolkit, or MEDCAT for short. And what this does is it firstly looks for synonyms of a concept or a diagnosis, and then it determines the context. So you can see a mock-up patient letter here for a patient with ET, JAK2 positive ET, and we're looking for cardiovascular risk factors and previous events. So it detects that the patient has a diagnosis of hypertension as well, and it also detects that they have had a stroke in 2012, but the family history of a heart attack in their father is not detected because it doesn't relate to the patient. The context is inaccurate. And this project resulted in some really interesting findings, which are summarized here on the left. One of the findings was that patients with high blood pressure had significantly higher rates of stroke and venous thromboembolism, and it's something that we should really try and monitor and treat aggressively in the MPN patient population. So just to finish off, what does the future hold with regards to patient-reported data and the use of wearable devices in healthcare? This was recently reviewed in the New England Journal of Medicine. Some of the areas that we should be aspiring to are connectivity between different healthcare providers, so hospital services as well as GPs, and perhaps acting as an interface for patient information. We would also want to provide systems that allow direct interaction with patients, and so that patients can directly access advice and information from their clinicians, whether that is their primary or secondary healthcare teams. And perhaps the biggest area of opportunity is the use of machine learning, which will continue to grow. And finally, we do want to aim to provide systems that are able to be used and cater for a diverse range of needs across a range of ages, socioeconomic and educational backgrounds. So I'd like to finish by thanking the team from MPN Voice, all of the patients who've participated so far, and the team at Sanias who've helped us to design this. I'm going to hand over to Debbie next, but John will introduce her. Unfortunately, I can't stay for the question and answer session, but Debbie is able to answer all of the questions about the app functionality. If there are any specific questions about the data, I'm happy to be emailed. My email address is on the microsite, so if anyone wants to email me, that would be great. Thanks.